we go.
Regional Manager for the Canadian Red Cross here in the Lower Mainland. Before we start tonight, I just wanted to encourage you to pick up any of the materials that you saw outside the door. Feel free to take those with you this evening and share them with your friends. Also, before we start tonight, I'd like to give an opportunity for our Provincial Director, Kimberly Narava, to say a few words. Kimberly?
Thanks, Christopher. I just want to welcome everyone to this talk. We've got a small group tonight, but this is a really special opportunity. I have to say that there's a lot going on in Vancouver this week. It's been a really busy week, a good week. We've got the Disaster Risk Reduction Roundtable that we had a lot of attendance at, and where we were able to announce a signing between the ministry, the government of BC and the Canadian Red Cross to help deploy emergency response units into BC in case of a disaster. There's a home health care summit about expanding home support needs. Right now, as we speak, there's another presentation, a major panel discussion in violence and abuse prevention, where the Red Cross is speaking on bullying. And this is in the wake of a horrible tragedy in BC where a young girl by the name of Amanda Todd took her own life. And this was planned long before that tragedy, but it's another activity this week. And of course, we have the benefit of having Dr. Robin Coupland here because of the Violence in the Health Sector International Conference that's being held in Richmond. And with all these activities happening, one of the things that really struck me was some of the commonalities between them. And around the need for organizations like Red Cross, for our partners in government, for organizations like, here we are in the Justice Institute, working so hard around how we can improve our ability to care for each other, how we can work in respecting each other at the local, at the interpersonal, at the provincial, and at the global levels, and looking for new ways to work together. Because all these themes are different topics, there's really those three undercurrents that are common among them. And so this is a really nice example of the JI. I'd like to thank the Justice Institute, who very kindly offered to host this event this opportunity came up on very short notice for us. And to thank, of course, Dr. Coupland, who I don't think he's changed his time zone. He is coming in and out for both this meeting and more importantly, the healthcare conference. And I'm just going to turn it over, so welcome everyone, and turn it over to Christopher to do a full introduction. Thank
you. The International Committee of the Red Cross, the ICRC, is an impartial, neutral, and independent organization whose exclusively humanitarian mission is to protect the lives and dignity of victims of armed conflict and other situations of violence, and to promote them and to provide them with assistance. The ICRC also endeavors to prevent suffering by promoting and strengthening humanitarian law and universal humanitarian principles. Violence directed at healthcare in armed conflicts and other emergencies is a massive humanitarian problem. It denies healthcare to millions of people who desperately need it. To address this growing humanitarian challenge, the International Committee of the Red Cross has developed the Healthcare in Danger Project. This project aims to draw attention to one of the most crucial yet overlooked humanitarian issues of today. The Canadian Red Cross and the Justice Institute of BC are honored to present Dr. Robin Coupland to talk about this most important project. Dr. Coupland is a medical advisor for the ICRC and since 1987 has worked across South Asia and Africa as a field surgeon on numerous ICRC responses. He has developed a public health model for armed violence and its effects as a tool for policymaking, reporting, and communication. His current work focuses, in part, on improving security of healthcare in armed conflicts through this Healthcare in Danger project. Please join me in welcoming Dr. Robin Coupland.
Good evening, everybody, colleagues, friends. It's a great pleasure to be here. I'm very honoured to be invited. I'm sorry we didn't give you more notice about this, but as Kimberly says, it was an opportunity not to be missed to come and speak to you. The Healthcare in Danger project has as its objective to assure the security and delivery of effective and impartial healthcare in armed conflicts and other emergencies. By other emergencies, we're talking about the civil uprisings that we're seeing in North Africa and the Middle East at the moment, for example. Those initials after my name, I'm just going to sort of guide you through the S stands for surgeons. That's my background, general surgery. I trained in the UK. C stands for college, school. The College of Surgeons in Edinburgh was actually founded the same year as Columbus set off with the view of finding India. He found another place on the way. But it's the oldest medical institution in the world. And the R, of course, is royal, because us Brits love things royal almost as much as the Canadians do. And the F is, fellow, one of the gang, and that's me, fellow Royal College of Surgeons. And I did 7 years of field surgery with the ICRC, and every day the consideration was our security. I'm not saying we lived in insecure environments all the time, but this is an everyday consideration. So at the core, we have a fundamental question. And that fundamental question I'll set up with a few anecdotes. Before I even started with my field work with the ICRC, I was working in a London teaching hospital, big institution. I was asked to go down to the casualty department to see a patient. I can't even remember who or what the patient was or what they had. But it was a Friday night, or it was a Saturday night in fact, and there'd been a soccer game in town. And nearby, and two rival sets of families found themselves in the accident department at the same time, and a fight broke out. And someone pulled out a knife, and the police were called. It was a big mess. And in fact, no healthcare was delivered in that emergency department for about 3 hours. A few months after that, I found myself on my first surgical mission on the Afghan border in Pakistan, a town called Peshawar. And I was loving it. I mean, it was the first time we had a small district hospital, but the patients were wounded from inside Afghanistan, and I was just slapping it up as a young surgeon. And the hospital was only about a kilometre from where we lived, probably less. And I got a call at about 8 o'clock in the evening that the patient had come to the hospital. Could I go down immediately? And I got in the car and I drove off down the road towards the hospital. It was dark. And a policeman stepped out in front of me and a carbine over his shoulder. And I thought he wanted to, I don't know, maybe check my driving license. I was quite surprised when he opened the door. He just got in the car. And then another policeman got in next to him. And then 4 more with their carbines. We got in the back of the car. And he sort of motioned that I should just drive on. I wasn't terribly worried. They seemed very young, very friendly. The sergeant had 2 words of English: Manchester United. I think it was meant to be some kind of bond between us, and they just said drive. And so I drove about 11 miles out of town, and they thanked me, got out of the car and left me there. Of course, an hour later I got back to the hospital. Where have you been? I said, Actually, I think I've just been hijacked. But I guess in a way it was, without any serious threats. But nevertheless, I was unable to tend a patient who needed emergency care. A few years on, ICLC Hospital in Kabul, massive bombardment of town. 200-bedded hospital, we received 600 patients in one day. And so the needs go up at precisely the time we can't address the needs, and we couldn't address the needs because the bombardment was so heavy the staff couldn't even get to work. So we were, this is absolute hallmark of these situations, is where the needs go up because of the violence and insecurity, but because of the violence and security, it's more difficult to address those needs. And the last little anecdote I would like to say was I met recently a doctor from one of these countries in the Middle East who said that it's more dangerous for him to drive around in his car with medical equipment than it was for him to drive around with weapons. To drive around with weapons, it might well be seen as those weapons being the means to protect himself. The medical equipment means that he was not working in the public hospital, therefore will be treating insurgents. And so, if by carrying medical equipment as a healthcare person, you're actually running a serious risk to your own life in those contexts. So the fundamental question is, what is the link between all of these? And the link is quite clearly security or insecurity. And the fundamental basis of this whole project is that you need a degree of security before you can deliver any healthcare. You cannot take on that relationship with the patient in a mutual trust context if your life is threatened or if you're frightened. And so this whole project is based on this fundamental that you have to be secure before you can deliver healthcare. Now, if I put up the statement, healthcare must not be attacked, obstructed or abused, you'd all go, well, yeah, that's fine, that's obvious. Well, is it? Why is there something wrong with attacking or obstructing or abusing healthcare? It's actually because the wounded and sick have a right to healthcare. If we're not careful, we promote the message that healthcare must not be attacked, obstructed or abused. We will actually put the concerns for ourselves on a higher priority than the concerns for the people we're actually meant to be treating. We can only expect certain protections because the people we're out to treat and help have a right to healthcare and should be protected. And so it's a kind of a cascade of rights and responsibilities. The wounded and sick have the right to healthcare, therefore we have a responsibility, and therefore that is why we are afforded certain protections. Some images, probably everyday images in many countries at the moment. Riots, conflict, ambulances running in. You can see the ambulance bottom left has been targeted by some large weapon, obviously. Top left is the operating theatre in Sarajevo in 1991. Bottom right, the beaches where we evacuated many thousands of wounded off the beaches to a ship waiting out to sea. We're not talking about just the wounded from conflict, but also every aspect of healthcare, including vaccinations, maternal child healthcare, etc. And bottom right, the issue of checkpoints is a recurrent story in this. And in one of the hospitals we are assisting, we did a brief survey and we found that 70% of the patients spend more than an hour and a half at checkpoints on their way in, for no obvious reason. These are some photographs that I took myself in northern Somalia quite a long time ago in my time as a field surgeon. And I went to this hospital to replace another surgeon who had been operating and a bullet simply came through the window and hit him in the shoulder. And you can see in the left-hand photograph that there's a whole boxes piled up against the windows. These were in fact boxes of intravenous fluids piled up to act as temporary sandbags. And we had yet another influx of wounded, top right. You can see the wounded are lying there on stretchers, but we wanted the stretchers because there were more wounded at the entrance. And when I asked them to get the stretchers back there, that was the first time I was assaulted by a patient. And then his brother said, are kill you as a kind of a standard response at that time in a hospital. We then had to leave for 3 or 4 days for security reasons, and this was the medical warehouse when we got back, being looted, and it took obviously weeks to resupply and reorder the warehouse. This is the ICRC hospital in Kabul, the door to the operating theatre, and just in the gutter to the left of the paving stones there, someone noticed there was a hand grenade. The pin had been pulled out, and the hand grenade probably been thrown over the wall into the hospital. No one knew why or when. We had to get the bomb disposal crew to dispose of this, and of course, in that morning, no operating was done. So these are different ways of showing how insecurity can actually impact, if not completely eradicate, notions of healthcare. So what can we do about it? I think that if I ask you to remember one take-home message, it is this, and this is what we learned from the anti-personnel mine campaign. Probably one of the most successful campaigns that the Red Cross has run in recent years. But we find there were 4 pillars to this campaign. The first is that you have to make people concerned. You have to have images. Now, in the mine campaign, it was dead easy to have images because we had wounded, we had disabled, we had mines, minefields, etc. But images in this one are difficult, and we're doing some photo agencies such as Getty are helping us to actually get appropriate images to show. You have to be credible, so when you go to Vancouver, you wear a tie, and hopefully more people listen to you because it comes from a nice institution, and you have to have data. These are the 4 pillars if you want to actually reach policymakers on a violence or security issue. Have data. Well, what gets counted gets done. I don't know who first said it, but it is so true. When I was training in surgery, there was a famous study that was published about a wound infection rate, a hospital wound infection rate in one of the London hospitals. And it was bad, and they decided they would do a study to study the incidence of wound infections in this hospital. And they set out to study. But what happened was that the wound infection rate dropped as the study was started. The results weren't out. In other words, the process of beginning to gather data had an impact before we even had the result. And exactly this happened in this project. We sent out messages to our field officers to say, please help us with the data gathering exercise. We want to know any incidents that you know of. And what the response was either, well, we'll do what we can, we don't really understand why, or sometimes we're saying, actually, thanks, Robert, we've been looking at this issue and not actually realizing, recognizing it for what it is, that is the insecurity, and this is something that we can work on. So policy at a field level was actually changing before we'd finished our study, which I will describe. But ultimately, it's all about insecurity of healthcare. This is the issue. So what gets counted gets done. I was asked to head up this study, and what we have is a special piece of software which I've developed with a researcher, a statistician in the University of Toronto. It's a Canadian connection to go with it. And basically what we do, we can take an incident of violence, a report, 2 masked men went into such and such a hospital last night and shot a patient dead. That who does what to whom, when, where, and how can actually be moved into a database. And thereby we turn qualitative data in reports to quantitative data. I can get pretty passionate about that subject, so but if anyone wants to discuss it further, I can give you the references and the methodologies. And what we did, we took all sources of reports about attacks affecting healthcare, any kind of violence affecting healthcare, from the 16 countries over a 32-month period. And in the 16 operational countries, and these were countries that had said in their annual planning cycle, we have a problem of security of healthcare in this country. We didn't name them in the study when we published the study because some of the countries concerned definitely did not want it to be known that they had any problems in their country in terms of security of healthcare. So we decided simply to leave it as a descriptive study and not say where the data came In total, we had 655 events, in which 727 people were killed, but more than 1,100 people were wounded, and 166 people kidnapped. This is the tip of the iceberg. Absolutely the tip of the iceberg. The methodology only captured a very small number of the events, and probably captured the more serious events where people were killed. More importantly, what the study showed is the nature of the violence. We can't say anything about the extent, but we could say something about the nature of the violence. This is very important. If you understand the nature of violence, you understand the threats and the vulnerabilities. And if you understand the threats and the vulnerabilities, it's in the threats and vulnerabilities that the preventive measures lie. And so we were able to say one form of violence of concern is military actors using explosive weapons and hitting, usually inadvertently, healthcare facilities. There is an issue of military and police personnel entering healthcare facilities for interrogation, arrest, harassment. They want food, they want treatment, whatever. But, and sometimes this was, if you like, legitimate and well done, and sometimes it was harassment and disruption of healthcare. It is legitimate for security forces to arrest someone in healthcare as long as that healthcare is provided when they take them out. But this was not the case in most of the situations that we were recording. The health facilities were taken over by non-state armed actors, usually for their own purposes, because they didn't want to. So an ambulance would be hijacked and used as an ambulance for their own people, for example. The military, in general, were entirely responsible for all the checkpoints, delays, and harassment. Attacks on the open road of ambulances was uniquely the domain of the non-state armed actor. Kidnapping of personnel was uniquely the domain of the non-state armed actor, either for money or ideological reasons. And likewise, expatriates who were targeted, this was uniquely the domain of the non-state actors. There's a layer in here, as you will well understand, that in this sort of context that we're talking about, there's also an elevation of common crime. And so some of the incidents that we described were captured by the methodology. It was simply someone being jealous, someone wanting to rob some money from a patient or whatever. What this did, just as one example, it highlighted what behaviour of the non-state armed actors. And when I presented this material to our directors, they said, well, actually, we've got to put high priority on this. Half of the incidents were the non-state armed actors. And we have an idea here from the study of what they did. This changed our policy towards the non-state armed actors. And so we've changed our approach to speaking with them. I'll come on to that shortly. It's important, perhaps you're thinking, well, how could you possibly influence the Taliban, for example? Well, there was an interesting event in April of last year. It's all in the public domain. The Taliban attacked a police recruitment centre using a disguised ambulance as the means of attack, and took responsibility for the attack. And this was condemned publicly by the ICRC. And then the Taliban said, well, actually, this shouldn't have happened. We're going to do an investigation, and it won't happen again. I'm not condoning the tactics used by the Taliban, but at least they recognised here that an ambulance should not be disguised as a suicide bomb, and gave an undertaking that it won't happen again. And to my knowledge, it has not happened again. There is, of course, the sort of everyday stuff which we didn't capture, that we know of just from experience. The arguments at the hospital entrance about whether someone could come in with their weapon, for example, or want to bring in more relatives than the one that we would allow. I mentioned staff getting to work. This is a major issue when there is disruption in town. How do they cross town to get to work? Are they happy to leave their families at home, etc.? And the relatives, a number of cases in the study where the attacks on healthcare staff is from relatives. And here I sort of should stop. We could talk for the rest of the evening about the issue of relatives. This is turning out to be a huge issue. In a number of countries, our health coordinators have been down to the local hospital and said, what is your main security issue? Thinking it would be bombardments, soldiers entering or whatever. And they say it's the relatives. The treatment is not cheap enough, it's not quick enough, it's not high enough quality. They get on the internet, they know what to expect, and they don't get it here. AlertNet carried an article 3 or 4 weeks ago. There are whole hospitals closed in Egypt because of threats from relatives. British Medical Journal 3 weeks ago carried an article about the issue of the extraordinary dimension of the issue of attacks on healthcare workers by relatives in China. And so, whilst you might say, well, the relatives issue is separate from the armed conflict, well, it's not. It's overlap. Because, as you've probably seen, for example, in the Gaza Strip, you see it on television, when one person is injured, 30 people run into the hospital demanding treatment now. And so we're at the moment, this has taken us a bit by surprise, and we're actually wondering just to what extent we take on this issue of relatives. We've even got so far as to think, well, I mean, what's an opportunity for national societies to provide support information, where are the pharmacies, relatives, where do they sleep, etc. So there's maybe something in the future for us there. And a common cry, as I mentioned. Have I discussed the problem now? I've told you about a study. We've got an idea of the nature of the violence, but I don't think I've even started on the real problem. Because the real problem is the impact on people's health because they are denied healthcare. This is enormous as well. A bomb at a graduation ceremony, the first graduation ceremony in Mogadishu for 30 years, where 14 medical students were killed, 3 doctors and the Minister of Health. You do a very simple calculation. That single act has actually denied Somalia 150,000 consultations per year because of that lack of medical capacity that has disappeared with one attack. It is estimated by the World Health Organization that 600,000 children on the border of Afghanistan and Pakistan will not be vaccinated against polio because of the insecurity. And in fact, polio will not be eradicated because of armed conflict and insecurity. And so the knock-on effects actually on the people of this violence and insecurity is enormous. Millions of people affected. Tens of millions. In fact, we've gone so far as to label this one of the biggest humanitarian issues today. Up until now, this hasn't actually been contested. If you follow our argument that there may be whole nations, the Democratic Republic of Congo is one, that's the only one that is well documented. Article in The Lancet has concluded that 40,000 people die per month from easily treatable diseases because healthcare can't reach them because of insecurity related to the conflict. On top of it, as we've seen in North Africa, Middle East, that when the trouble starts, somehow the trouble focuses on the hospitals, the ambulances, because the new forms of conflict take place in cities. The wounded, whether they be military or civilian, will go to the general hospital. So it becomes a focus for everyone. I'm concerned about my relative. He hasn't come home. Is he in hospital? The security forces know that there's good information to be had from wounded people. So this takes on an immediacy. It's universal immediacy. And it's a very, very complex, multifaceted problem. And surprisingly, it has been largely unrecognized until today. The 16-country study, which I've just described as the first of its kind, hasn't been studied before. There's very, very little academic work done on this from a public health perspective, and I will come on to that shortly. And whilst there may be, for example, in WHO in Geneva, World Health Organization, there's a system for constantly hoovering the news and the website for new infectious diseases. There is no central repository or no surveillance of violence affecting healthcare. It doesn't exist. The good news is that the World Health Assembly in May actually mandated the World Health Organization to begin to look at this issue. We don't know how far it's going to get. So the ICRC, for its part, has initiated a 4-year project. A campaign, communication campaign to raise awareness and concern about the issue. This has actually has gone very well up until now. We want to do more and better at a field level, do more to promote security of health facilities and the people working in them. For example, reorganising entries of hospitals, so protecting the staff from the convergence reaction. Adhesive, anti-explosive sheeting on windows, etc., etc. We're going to run a series of workshops in this year and next, or the remainder of this year and next, where we're hoping to make strong recommendations that can be taken to governments and be presented at governmental conferences later on. All of this is supported by communications, and ably supported by communications, and some of you have seen these posters outside. I didn't die because the war forced me into a refugee camp. I didn't die because of the dirty water I had to drink gave me cholera. I died because the fighters stole medicines and killed 2 of the health workers. Here we have the ultimate victim, the person who dies because he was denied healthcare. We have to have the ultimate victim in the picture. Interestingly, when we were pitching for different agencies to actually give us this work, 5 of the 7 agencies that were interested only wanted us to say, have Red Crosses with bullet holes as the theme. We said, sorry, no, that doesn't work for us. We have to have the victim, the ultimate victim, has to have the highest priority. Another poster, a different sort of thing, this is much more about access. My baby didn't die because the midwife was killed in an explosion. My baby didn't die because I was in labour for such a long time. My baby died because our men hijacked the ambulance coming to ambulance. And you will see also the different contexts, different continental contexts, cultural contexts portrayed by these posters. There are 4 in total. And there have been, what is interesting is, it's the first time the Red Cross had images of death and dead bodies on posters. Highly controversial, rejected in its concept by many of our offices. And suddenly they turn around and find that people actually quite like to have them in their offices. Not necessarily at home, but certainly in their offices. And these can be downloaded from our website. So the themes of these workshops, obviously there's, our line is that the existing international humanitarian law, existing human rights law is adequate, it needs to be better applied. What we need is better development of domestic law. For example, Colombia, to our knowledge, is the only country that actually has a law that says that a doctor or a nurse cannot be interrogated by security forces just because they're treated as suspected rebel. This is actually quite something. There are not many countries that have such laws in place that protect health workers. We're doing a big one, and it'll be in Ottawa next year on hospital security, many aspects of that. We're doing one in Cairo in 2 months' time on picking up on the events in the Middle East and North Africa, and the healthcare on the street. I was there in Cairo a few weeks ago and had the honour to meet the ambulance service of Egypt. And of course, during the uprisings, the ambulance service of Ministry of Health, that's government. Therefore, that's the other side as far as the demonstrators are concerned. But they got round us, they used radio to make sure that everyone knew who they were, that even though they were government, the treatment was impartial. They said the biggest thing that we can do is to train our people in confronting a crowd. This is really important. So then we realised there was a whole wealth of experience there that we have to capture so we can move it on. Military practice, we're really only after two things. That is the checkpoint issue and search operations in health facilities. It does not take 5 hours to check an ambulance for explosives. You do not have to put a dog into the back to run over the patients. You do not have to arrest the doctors in the search operation before you can actually talk to patients or interrogate them, etc., etc. There are no standard procedures for military personnel in these issues. So all we're wanting is some very simple, practical measures so they know what they can do, they can't do. The role of national societies, perhaps we can discuss that afterwards, but we think there's a lot that national societies can do in this domain, and this will be explored in Ottawa and also in Tehran next year at 2 of the workshops. And what about the health professionals themselves and volunteers? I'm happy to say that we've, just as of 3 weeks ago, published a small book on the responsibilities of healthcare personnel working in armed conflict and other emergencies. This draws off humanitarian law, human rights law, and medical ethics, and it also is the first of its kind. You'll be happy to know we're not organising a workshop called the non-state actors in the world and get them around the table, but what we are beginning to do is to speak to them in a different way, to speak to the people that might have influence, such as clerics, academics, and to begin to actually understand how and why they might attack healthcare and how they can be brought to understand that there is traditional neutrality of healthcare and it's not in their interests to endanger healthcare in any way at all. So what does it mean for you? We can certainly, with Kimberly, we're having a discussion about what this would mean for example, the Canadian Red Cross. But if you're not from within the Red Cross, I think there are some other things as well. First of all, to be aware of the issue, to talk to people about the issue. Make it institutional. This is really important. We had a symposium in London where we basically launched this issue to the health community. And this was picked up by institutions, by Royal Colleges, by the World Medical Association, who now have their own working group on this. Incredibly influential, picked up very rapidly, reported widely in the mainstream medical media. Make it academic. I referred to this before. There is nothing written in the domain of health and human rights on insecurity and attacks to health. It's empty. The discourse on the rights to health never mentions insecurity. Our study, 16-country study, is the only one of its kind at present. We hope that there will be others. And there's very, very little on the, if you like, the knock-on effects which I described. There are other studies that could be done, such as the traditional perception of neutrality of healthcare. Is it traditional, or is it something even more visceral than that? Does one automatically respect the carer as the healer? So there's a huge research agenda waiting to be picked up. For health professionals, we say know your responsibilities and also know your rights, because under certain circumstances your rights might change, especially if you're military or if you're working with the Red Cross, Red Crescent movement. And basically to be a part of the healthcare in danger, what we call it, community of concern. And I hope that what I've said has caused you some concern this evening. Thank you very much. I think Christopher might be coming down to say if anyone has any questions, I'd be happy to answer them. Do you want to say that? Right. So if anyone has any questions, I would be very happy to try and answer them. Yes, please.
First of all, thank you very much. Very interesting topic. I'm just curious, and you touched on it a little bit. It used to be, I'm worked in some of these conflict areas. It used to be that surgeons, doctors, healthcare workers had such great respect. You didn't touch them. They were the elite. You know, you let them do the work that they wanted to do to protect people and to care for them, etc. Why do you think that this is happening so much these days, where the clinics are being bombed, or using ambulances, example, to do this? Is it because there's more media, so we find out more these days quicker, or is there a reason behind this occurrence?
Well, that's a very, very interesting question. I'd like to think that I retained some of my scientific attitude in this. And I really don't know whether it is a problem that's increasing or we're becoming more aware of the problem because there's greater attention paid to it. When we launched this in August last year, we launched it on the back of the study. Some of CNN, BBC, Al Jazeera, the big ones, took interest. Articles describing the study and our concerns, but the headline was, Red Cross says attacks on doctors tell them drugs. That just don't matter. Attacks on doctors on the increase in war zones. We'd never said that. But that was kind of that was their take. So I can't answer your question. Maybe in some years we will know. What I do know is that the 16-country study is online. You can get it off our website. That really was the tip of the iceberg. And there were thousands upon thousands more incidents. And internally, we are keeping the same process going. And we had 655 in 30 months for the study. We got to 655 when we really got the thing rolling. We got 655 within 2 months. And so now that our field officers know what to look for, we're of course detecting it more. And what was also interesting in the study was when we analysed the outcome by source, the media sources were reporting on deaths, injuries, explosions, spectacular kidnappings, and the internal confidential reports that we had access to were all about checkpoints, denied access, stuff that was very politically sensitive, but we weren't going to make a noise about it in the public domain. So even the sources differ. And what that means is that the media do not have a complete picture because the confidential stuff is different. So we haven't got a complete picture yet. And it will be very difficult to prove whether this is something that is getting better or worse. Sorry, I can't answer. Please.
Yeah, are there any countries the Red Cross has had to pull out completely because it's just too dangerous to work?
Yeah, unfortunately, quite a few. We've just closed our school in Pakistan. We have no expatriate staff on the ground in Somalia. The kidnapping risk is too high. We pulled out of Chechnya because we had 6 hospital staff assassinated one night in '96. So yes, there are unfortunately a number of places where it is simply too dangerous. Interestingly, I'm quite often asked, well, isn't it always the case? This kind of question. You're putting yourself in harm's way. Isn't it inevitable that at some point you will get attacked? And isn't the Red Cross just a target? There's one thing I do know, and that is our security depends entirely on the communities knowing who we are and what we do. The emblem is a vehicle to that. But if the communities don't know who we are and what we do, then we have a security issue. It's by far the greatest security guarantee.
Thank you.
Please.
I noticed that I'm guessing that most of your data is coming from conflict zone areas of less than stellar national security. I was curious. I did a paper when I was doing my bachelor's degree on assault on paramedics in the pre-hospital field, and one of the biggest issues that we saw was an increase of violence against healthcare workers in, we'll say, relatively secure countries, let's say Canada, the U.S., UK, Australia, and this seems to be again increasing to the point that the London Ambulance Service also had a campaign, a very what I was curious about, have you thought of chasing down data from, say, the National Health Services or others on impact or assault on healthcare providers in stable countries as well? So I don't think it's just these conflict areas that are at risk. This is a becoming endemic everywhere.
I completely agree. We haven't chased down the other data, partly because we are the organisation who we are. We tend to focus on the conflict and sort of widespread violence. There's a huge piece of work to be done on exactly this. The phrase that stays in my mind when we went to Egypt, hospitals closed because of assaults on staff. The customer is not satisfied. Well, why not? Is it because there's such a great expectation of healthcare now that you've got to remember why patients are called patients? Because they had to be patient to see anyone. Well, they're not patient now. And there is a right to healthcare, and that is demanded now, the highest quality. And everyone now can see what that quality is. And so I actually wonder whether healthcare as an exercise has actually painted itself into a corner in a way, to say, we can do this, we can cure this, aren't we wonderful? So when we can't provide, we're actually now generating our own security risk. And I think that many of the countries where we're working, that is pretty much the case. And if you think, for example, of the London riots, the riots in Paris, as you say, that stable countries, I agree with you. I don't think they're that far away from situations where hospitals will be increasingly the centre of violence. Because of that, exactly because of that, the expectation is now very, very high. And these are the situations where it cannot be fulfilled, that expectation. This concerns me. The World Medical Association is also very concerned. Madam with glasses.
I'm interested, I don't know how much you're able to say about it, but just the work that the ICRC is doing with non-state actors, I imagine it would differ greatly from the kind of work that's being done with militaries to sort of address some of these concerns. I'm just sort of interested in what kind of work you do with non-state actors. Is it mostly education or what exactly is it?
The ICRC, in our field operations, we will basically try and have a dialogue with anyone that's carrying a weapon. And we're going to be high and mighty about any of this. And what it comes down to is basically dialogue, more dialogue. We have for example, a first aid training in Afghanistan. We do with the Taliban, which has brought us considerable criticism. But that is a vehicle for dialogue, and more dialogue, and more dialogue. And so there is not an opportunity missed to make sure that these actors know who we are, what we do, basically. And mostly they are respectful of us, I'm happy to say. And many of them are not the wild terrorists as we're led to believe. Bear in mind that Nelson Mandela was apparently a terrorist, etc. So we have quite a good dialogue with many such groups, and as a general rule they respect us pretty well. What we'd like to do is to expand that respect to all of healthcare. But if the treatment in the local hospital is not impartial, unfortunately this was frequently the case, then they are generating their own security risk. Yeah.
What the sense is around appetites of academic journals such as Lancet or British Medical Journal carrying papers on the topic of negative outcome as a result of violence against healthcare?
I'm happy to say that the Lancet carried a huge piece on this in 2010. Len Rubenstein was the primary author. It was the kind of the central work on this. The British Medical Journal covered the launch with an editorial. Strangely, just today I was asked to do an editorial for the New England Journal of Medicine on precisely the subject. So that's 3 of the big 4. And I can assure you that this subject, journals are really, they'll lap it up if it's offered to. Because it is new and it is such an enormous issue. Yes, please.
I'm familiar with a lot of the NGOs nowadays requiring security partners to join them in delivering their care, humanitarian aid, and a number of the organizations that do provide medical care do not use these security support entities. Are you finding that that it's possible that they're not coming in with these types of security entities, that they're being seen as vulnerable, or previously those types of agencies with those entities have created animosity? I'm just curious, do you think there is...
Yeah, it's a difficult one, that. It may provide an immediate security or a sense of security, but it can go horribly wrong once the shooting starts. Those security agencies can be very much affiliated with one side of the conflict, therefore the notion of neutrality is evaporated. And so, I mean, we did make a very controversial decision many years ago to have armed guards in Somalia. But, I mean, these were the local guys with guns, but we had no other option. It was a very, very difficult decision. But we're still not in there. So the security issue is dire, and that was clearly not the solution. Our policy is very much not to go down that line. Some agencies do, but I think as a general rule they realise it's a mistake. Again, it comes back to this neutral, impartial humanitarian action. Tell everyone who you are, what you do, and that is your best security guarantee. It's not 100%, but that's one thing I'm sure of. Thank you very much indeed.
Thank you, Doctor. And thank you for your very informative talk and discussion of the challenges that are facing healthcare workers. As Canadians and humanitarians, we have a role to play in your efforts, and safeguarding healthcare cannot be addressed by healthcare workers alone. Your publication, Healthcare in Danger, Making the Case, is available at the rear of the theater and on your way out. And I encourage everyone to take a copy of that and take a look at the last page, which has 10 action items that you could take as an individual or as a group to address this in your own communities, or in your own lives, or as part of the ongoing Red Cross and Red Crescent movement. Thank you again for your talk, and thank you all for joining us this evening. Good night.
get in the right lanes.
Yeah, it's tricky.
What do you tell them?
Are you from
You what? Thanks again.
Would you like to get off the ramp or?
I'm happy on the ramp.
Hi, Chrissy. And Lori. Thank you very much for and that's actually what I'm just curious about. I've lost the passion.
Oh, right.
I was online doing